Hello, and welcome to the Remote Patient Monitoring Virtual Summit. This is Vanessa Palmer-Desiato, Project Manager at Excelgent Healthcare Media and moderator of today's session, Change Management Strategies for Delivering Healthcare at Home. Before moving on, I'd like to take a moment to thank our sponsor, Current Health. Current Health is the leading enterprise remote care management platform that enables health systems and pharmaceutical companies to deliver patient care within the home by identifying at-risk patients and coordinating intervention within a single platform across all patient populations. We will begin with a discussion with our speakers, followed by a question and answer segment. Audience members can submit questions at any time during the session using the Q&A box on the left-hand side of the screen. A recording of this session will be made available later this week. Today's session will play via your computer speakers, or if you'd like, you can use headphones if those are available for you to plug into your computer. We do not have a dial-in for today's presentation. For all technical matters or difficulties, click the help icon at the bottom of the screen. Now, I'd like to introduce our speakers for today's session, Dr. Brett Oliver, Chief Medical Information Officer at Baptist Health, Dr. Eric Alper, Chief Quality Officer and Chief Clinical Informatics Officer at UMass Memorial Health, and Christopher McCann, CEO of Current Health. With that, I'd like to invite Chris to begin today's discussion.
Thanks very much, Vanessa. Hey, everyone. Thank you so much for joining, and a particular thank you to Dr. Alper and Dr. Oliver for making the time today. I think everyone will learn a great deal from Dr. Alper and Dr. Oliver's perspective. I'm going to do my best to talk as little as possible in this, and let my esteemed colleagues here do all of the talking. Maybe first I could ask, maybe starting with Dr. Alper, maybe you could give a little bit of an introduction to yourself and UMass, and specifically what you are doing as an organization around healthcare at home.
Great. Thanks so much, Chris. So I'm Eric Alper. I'm at UMass Memorial Health in Worcester, Massachusetts, Central Massachusetts. We have 4 hospitals in Central Massachusetts and a large ambulatory presence. And, our hospitals have been, in particular, our medical center, the tertiary care academic center, is chronically overcrowded. We always have orders in our emergency department, and we have decided in the last several months to move forward with this approach to build a hospital at home. And I think that this is in recognition of a number of different factors. First of all, the fact that the growing evidence that it's possible to take really great care of patients in the home. We've been talking about this for a while. I think now that CMS has approved the waiver to move forward to be able to generate some revenue and to bill for patients that are taken care of in the home, that kind of pushed us a little bit over the edge. So we've been working very diligently to stand up our hospital at home program. We're also talking about potential next steps for doing some additional remote patient monitoring of patients at home as well, but that's a little earlier. We're not yet live with our hospital at home program. We're anticipating going live with that in August, so very close to that. And a lot of good experience so far, but we haven't taken care of our first patient yet.
Wonderful, thank you. And I guess same question to Dr. Oliver. Obviously, you're working with patients at the other end of the hospital as they leave. Do you maybe want to introduce yourself and Baptist and what you've been doing in the space?
Sure, thanks. I appreciate being here, and I'm anxious to learn from Dr. Alper as well. Brett Oliver, I'm a family physician and the Chief Medical Information Officer for Baptist Health. We're a 9-hospital system across Kentucky and Southern Indiana. We also have a large ambulatory presence. We have about a 1,500 member provider ambulatory group, and we have been primarily focusing our RPM in the outpatient setting, and have talked about hospital to home, are anxious to learn more about hospital to home, but operationally we just weren't quite ready there yet. So we do have some capacity issues at times, but it sounds like that's what drove Dr. Alper perhaps earlier than us in terms of strategy. We definitely see the future in the value-based world surrounding hospital at home, RPM. It's interesting how that oftentimes gets used synonymously, but I think obviously very differently. RPM is just a small part of the hospital at home piece as you start digging into it. But we utilize remote patient monitoring, continuous remote patient monitoring prior to COVID a little bit. As Chris is well aware, we had a pilot going on with COPD and CHF patients trying to reduce readmissions when COVID hit. And we pivoted and utilized it for our COVID patients, both for surge planning, capacity planning, as well as when we had the unknown of COVID, not understanding the quick deterioration on some patients, et cetera, when we could safely send them home. So we can talk more about that later. But now we're pivoting back, still using it for COVID patients, but we've got some outpatient CHF clinics that use it, and likely some neurology and perhaps even some mother-baby issues. So thanks.
And I guess following on from that, Dr. Oliver, what were the kind of key considerations and some of the biggest challenges that you've had in delivering into those different populations that you just talked about?
Certainly with COVID, it was the rapidity with which we had to have it done. You quickly uncover where those inconsistencies are. The technology was the easy part. It was maybe 25% of the meetings and emergency meetings and things we had set up, where 3/4 of it was operational. You quickly realize, even though we utilized our home care team, our home health team, we had that structure stood up, we had the communication pieces stood up, so we utilized them to participate with our COVID patients. But we don't have our home health team in every location. We're a CON state, and we didn't have that in certain areas, so we had to work through that. And just realizing, not inconsistencies, but just the variability in our workflows at each facility, where devices are stored, who puts the device on, who's going to pick it up. It varied by location. So just trying to get all of that coordinated, while at the same time, during the initial COVID surge planning, trying to figure out what do we do if we need to utilize these devices from a hotel, from a college dorm, some of that. So fortunately, we didn't have that extreme surge and didn't have to utilize it in that manner, but going through some of that planning was certainly a challenge. But really, I think the other big challenge for us initially, because we were standing it up so quickly, was how do we avoid segmenting the care? You've got the data coming in from the devices. You've got the home health nurses that have other clinical data that they're bringing in. None of that was connected. We didn't have time for that. And so in a perfect world, we would have our home health team on our EHR, our RPM data coming in, and then the clinicians that are helping make those decisions are also there. So I'd say those are a couple of things right off the bat.
Why don't I just react to that, if that's okay, and just say that when we started our project to work on the hospital at home, we're at UMass Memorial. We're an Epic shop. So we've been live on Epic for about 3 years, and we had decided that we had wanted to basically use our Epic system as much as possible to continue to take care of our patients that are part of the hospital at home program, like we would any other inpatient. So we're continuing to use Epic for the documentation, for the ordering, for the patient movement, and we're going to be trying to use the radiology. We order radiology studies. We get a device that comes into the home, captures an image. It will come back into our Epic system through our partners in the community. So that has been for us one of the biggest challenges, and in working obviously closely with Current Health as well to figure out where the points of integration are, to just like you said, Dr. Oliver, to make sure that patients get the devices connected correctly, to make sure that they're working and broadcasting to Current Health, but then also to have that data flow back into our electronic health record in a way that makes sense for the providers. If we're measuring the vital signs every minute in some cases, then do we really want every single one of those values to go into the system? So how do we create the right bridge, the right type of interface that is going to wind up giving our clinicians the information that they need, not too much, not too little. So that has been, that technology aspect of it has been a major piece of our implementation so far, and some of those have been among our larger challenges.
I think.
Can I jump in, Chris? If you don't, can I ask a question along those lines too? Because I'm curious. Because one of the challenges I would see too with a hospital at home is we're an Epic shop as well, and if you're documenting and ordering in Epic, then how do you close that loop? Are you utilizing and I know you're not live yet, but I think it'd be interesting to hear how are you utilizing like your third-party vendor, whether it's imaging or Current Health, to close the loop on that order, so you don't have outstanding orders out there? Has that been a challenge?
Yeah. Yeah, it's variable at this point still, that some of our partners in the community are going to be using a paper workflow, and then we'll fax the results back to us. In some cases, we're building interfaces to their system so that they'll be able to receive those orders electronically and submit back their results, their notes, their reports electronically as results, and we'll be able to close out those orders. So it's been a journey with each one of the different vendors that we're working with.
Thank you.
One of the, I guess, the biggest things we've learned is that the patient that's selected is like critical to success. So I'm wondering, maybe, I know Dr. Alper, you're not live with your first patient yet, but how are you thinking about population selection and which patients are the right candidates for hospital at home?
Yeah. So this has been a really high-level initiative driven by our CEO that's gotten a lot of support, top to bottom in the organization. We've put together a clinical operations work group that includes our series of hospitalists. We've brought on a new medical director for our hospital at home program. We've got emergency physicians and a series of nursing staff who all are participating in a number of different meetings, but in particular, a clinical operations work group, which has been helping to define the inclusion criteria, the exclusion criteria. Now, we've tried to be selecting largely the kinds of lower acuity medical inpatients that we typically feel like we could take care of very safely at home. Your patients with pneumonia that are not on high oxygen flow, very low risk that they would deteriorate and need to go to intensive care. Things along those lines. Our expert group has been meeting for each one of these different conditions. We've been putting together what our team has called the baseball card for them. For each one, what are the inclusion criteria? Who we would think about for that? What are the exclusion criteria? What are the things that we're going to be treating with? Are there any studies that they ought to have before they wind up leaving the emergency department to go to home, et cetera? All the protocols, orders, and order set information that we want to have included. So that kind of standard baseball card approach for pneumonia and syncope and AFib, and each one of the kind of the target conditions that we identified initially has been very helpful for our team.
Following on from that, how have you found engagement with, obviously in the CMS program, you have to admit from the physical facility or the ED, and I think one of the challenges we've seen is the clinical mindset shift that's required in the ED to say, hey, we're going to manage this patient at home rather than in the hospital. How have you found the engagement with the ER physicians, ER clinical staff, to the idea that they're going to be putting more of these patients home than perhaps they otherwise would have historically?
Yeah, some of the patients that we are going to be taking into the home are patients that would otherwise be border patients in the emergency department, and sometimes that could be for, significant number of hours in the ED. Our ED nurses and physicians are very motivated to get those patients placed in their ultimate destination, and I think they will be very happy to have, if we can get patients discharged home and to really great care with an outstanding team that's going to be taking care of them, then that's going to be, I think, a pretty easy sell for them. We are doing some of that kind of academic detailing with the ED team, with the hospitalist team, to have them think about this as a viable alternative for patients instead of waiting for them to go to the hospital. We've hired a series of, some of the nurses that we're bringing into our program are emergency department nurses. We have an ED physician as one of the main members of our team. So we're going to be working from the inside with the emergency department to be proactively identifying patients who we think are going to be meeting criteria for our program. So I think as long as people meet criteria, we're going to find them, and we'll have the support for our team to get them discharged home.
And Dr. Oliver, I know from our experiences together that I guess the patient engagement and the clinical team engagement's also been critical for you, and you all have had a bit of a journey on that as well. What have you learned and Baptist learned from a patient and clinical team engagement perspective?
Probably two answers to that in terms of COVID and non-COVID. You know, COVID was, because it had everyone's attention, was a little bit easier to gather that engagement. I use the example of one of my patients that went home with the device and did well, and it's like 30 days. She's doing fantastic, and we called to let her know we're going to come pick it up, and she lives by herself, and she was like, "Do you have to? Can I hold on to it?" And she liked the idea of someone checking on her because it was still so scary, to have COVID. Whereas, our experience initially with COPD and CHF, it was really important for us. We learned a lesson, I think you'll remember, Chris, to get the care teams, buy-in's probably not the right word, but give them the why perhaps better than we initially did. Give them the scripting that's needed. It was sort of like, we're doing this pilot here, put this on your arm and you're going to wear it and we're going to get some data and good luck, versus saying, this is part of your care plan. This is why you're going home now, because we're going to be able to continue to monitor you, and just changing that narrative. And, I certainly learned with that to give the scripting and to really have the why presented. I mean, that probably goes for anybody when you're asking to do something different, giving them the why. But when it corresponds to your organization's values and goals, I think it's a little bit easier in kind of pulling that all together. And that takes some work, and communication is always a challenge. Probably not giving any insight to anyone on the call there, but it's communicate, and then try it again. So yeah, I think that those are the two big things: was getting the buy-in and the why to our staff, and then helping them with that, giving them that scripting. Because once we did that and understood, you're not going to go home now without this. If you want to go home, this is how we're going to monitor you, and this is why. And then I think, Chris, when you have some anecdotal stories that you can share with your teams, with your patients, we were fortunate to have one straight out of one of our hospitals. If we were doing it for COVID, back to your question about inclusion criteria, we just wanted to make sure with surge planning that we used it, knew how to use it, knew how to set the alarms. And so we didn't put a lot of parameters on our hospitalist team. We didn't have time to go through it, bit by bit. And I'm kind of glad we didn't in that regard, because we had a patient sent home with COPD that deteriorated, and her life was saved because of that. Got back care in time. No one recognized it until the monitor went off. So, if you could take that story and share that with your nursing teams, your care management teams, your physicians, wow, that's impactful. And, we're all motivated by stories probably more than a slick tip sheet or something from our marketing folks.
Yeah, and I think the why point is we've seen that everywhere. Especially with the patients, understanding why this is important to them, why they're being asked to do this. There was a patient for us just yesterday who had been in hospital for 6 weeks. This is a patient in the UK, had really limited visitors because of COVID, and the clinical staff said, "Hey, we're going to give you this remote patient monitoring product and use it as a way of getting you safely home." And for that patient, the fact that they could get home and could get visitors because of that was like, cool, give it to me. I'll do anything if I can, I can get home. And that, personal value for them, and the fact they could go home and feel safe and secure was a super important part of their adherence to the subsequent program.
Yeah, and one of the other ways that I guess I would say that we've been advertising this internally, but just appealing to everybody's knowledge, that if you had a choice about whether or not you could get the same level of care at home versus in the hospital, then which one would you choose? I think, most people, when they're not really, really sick, would much rather be at home, where they're surrounded by their family. They have the ability to use their own bathroom. They don't have to be in a Johnny. They can eat whatever food that they like within reason. And that it's just a much more pleasant experience. And while you have, again, the outcomes that support that they're going to have just as good outcomes as if they were in the hospital without some of the morbidity, then, I think, again, making sure that patients are excited about this as well is part of our the way that we're going to be marketing this.
Yeah, absolutely. One of the, I think, things that we see in hospitals, health systems being nervous about, whether it's hospital at home, whether it's transitional care or chronic care, it is the, staffing requirements and infrastructure requirements around that around that program. Dr. Alper, how have you been thinking through staffing within UMass around that hospital at home program specifically?
Yeah, that's definitely one of the most significant pieces of the program. We are anticipating that in order to meet the expectations for the CMS waiver, then we need to have at least 2 nursing visits in the home each day. And we need to do at least 1 visit with a physician each day with a advanced practice provider. And that one can be through telehealth. So we're staffing largely to meet those major requirements. And we've got some other requirements as well, to have some care coordination, to have some patient care assistant who's able to handle some things like supplies. And we're thinking about how we're going to be able to staff up our program to be able to accommodate the number of patients in order to meet the needs of the organization. We're planning to start with 5 patients to start. And in order to do that, to provide basically 2 visits a day for 7 days a week, that is going to be about 5 nurses for us to cover that volume of patients full time. And then we want to be able to rapidly staff up to 10 and then subsequently to 20. And in order, just today we have a phase 1, we've got 40 patients waiting for beds in the emergency department. And, again, I think that to be able to decompress even 5 patients would be a huge benefit for the hospital. So I think that, getting the staffing available, the nursing staff, the physicians, I should mention the physicians as well. We're going to be using our hospitalist team primarily to drive the physician staffing for this. We're going to use our existing hospitalists who are going to do part of their time doing this and part of their time in brick and mortar. Interesting discussion about whether we want to have dedicated home hospitalists. And there are some of those folks out there, people who want to work to take care of those patients exclusively. So we're having discussions right now about whether we want to be recruiting those versus whether we want it to be embedded within our hospital medicine program. And there it's pros and cons to both models.
I mean, clearly you're making a sizable investment into this program. And I think one of the questions that we hear from people is that given CMS has only created the model currently for the duration of the public health emergency, what's your view on kind of future payment model and what CMS will do around that model? And what's been your thinking internally around that as you've thought about this investment?
Yeah, I think, what I've seen written about this is that it seems highly likely that CMS will continue this model. And part of the reason is because you got 3 things happening here, that patients are happier with it. You get equal or better outcomes at lower cost. And if that is the case, then, why wouldn't you continue to invest in this model? I think the fact is that we also get that additional benefit from this program of getting better utilization of our inpatient facilities. And if we can take some of those patients that really don't need to be in the hospital, and we can get the people who really do need to be in the hospital, including patients who are, we're getting transfer requests from other hospitals, patients who are very sick and sometimes are waiting a long time in order to get into the hospital, or in some cases go elsewhere because we don't have a bed. If we're able to capture some of those patients as well, then that's revenue that we're currently losing that would be part of that value equation for us as well. So there are a number of reasons that we think that this is going to be a worthwhile investment. And I think the writing is on the wall that this is here to stay.
I guess changing tack slightly, Dr. Oliver, I think, and we certainly learned this together as well. I think the temptation when you start moving more healthcare into the home is that you try and effectively completely replicate what's done in the hospital in the home, and that's also true for thinking about alarms. And obviously, alarm fatigue is a challenge. It's an even bigger challenge when the patient isn't in a room that you can just walk down the hall and get to and check on. How do you think about designing those kind of clinical alarms and risk stratification?
Yeah, so at the time of COVID, we had some remote patient monitoring that we just weren't utilizing. And so we had some baseline alarm settings for some COPD patients. So we kind of sat down with that. Fortunately or unfortunately, at that point in time, this was March of last year, we were starting to see sort of a mini surge and watching some of these patients deteriorate rapidly. So our meetings with our clinical experts, when it's so new, I'm smiling because we ratcheted those alarms down way too tightly. It was pulse ox less than 94%. It was when you look back on it, it seems silly, but at the time that made all the sense in the world because we didn't know. And so I think it's a very, very good question and something to really think through before you implement where those alarms are going to be. Do you have some data to go by? Certainly, I think with CHF, there's good data out there, and COPD. With COVID, we didn't have that. I'm sure Dr. Alper has it for other circumstances, clinical situations as well. But honestly, the key, you come up with your baseline, and being able to individualize it for a patient is critical. And then having a quick turnaround process so that if you're making mistakes, even on an individual patient level, you can adjust that. And, I think that's where having a platform that can look at multiple vital signs integrated together. I mean, we've had some of this stuff for decades that you just had on a piece of paper, whether it's CHF and I gain 2 pounds and I take an extra Lasix and then I call if it's more. We've had that. We just haven't been able to automate it, and we haven't been able to detect it until the patient's feeling bad or notices that. So I think the exciting part, or at least one of the exciting things for me in the RPM world, is to get this data quicker, analyze it per patient, and then be able to act on it and change those alarms, whether it's tightening it up or relaxing it for the patient so that you can improve that experience and most importantly, improve the quality and the outcomes. But yeah, we ran into some bumps there, particularly with those COVID patients, and it not only affects alarm fatigue, but patient adherence. Again, COVID was easier because they were afraid of that. The CHF patient that's been in and out of the hospital 7 times in the last 15 months, they're not afraid of it. They're inconvenienced. And so you have to sell it a little bit. And then if you're going to sell them by something that keeps them up at night, continually going off, that's a tough one. So it's part of our intake process now. We've got sort of a centralized form. And so we can get an idea up front what the clinical people are thinking, clinicians that want to bring that use case forward. But I think it's really important to have a quick turnaround cycle as part of your governance or your processes.
The patient adherence point is really interesting because we saw recently in a COPD population that we were having a 50% refusal rate at the point of enrollment, which was really, really high. And when we and the team at our partner dug into that, what we found was that these patients were not accepting it because they thought that they were going to be told if they were having an exacerbation of their COPD, and if they knew that, they were going to be brought back into hospital or have to do something, and they were like, hey, we just don't want to know that. Like, I don't want the hassle. So I think it's those like unexpected kind of patient dynamics that become really interesting to try and work through and solve. You touched a little bit in that conversation about how you're thinking about, I guess, response to those alarms. You talked about Lasix. How do you, if you flag the patient that's at risk in the home, how right now are you responding to that? And I'd also be curious to know how you as Baptist think about that in the future. Where do you think that will go in the longer term, that intervention in the home?
So right now we're still sending COVID patients home with the device. And with that, we utilize our home care team. So we actually have a third-party monitoring service that takes that first call, make sure it's not a battery issue, patient just doesn't have the device on. And if there's a true clinical alarm that's going off, then it gets forwarded to our home health nursing team. And again, we did that. It's worked out very well, but we did that because they're used to being on call. They're used to receiving data from patients, that kind of interaction. What's been a little bit more of a challenge in other clinical scenarios, like our outpatient CHF clinic, well, there's not a natural sort of care manager, nurse that's integrated into that role. And so who does take that call? If it's not? And so we're still working through some of that. But I think that part of that should have been done on the front end before you get that deep in it. And again, lesson learned there. We thought we had some things in place that fell through. Yeah, but if you've got a good intake process, I get a lot of interest in another use case. And then when they have to kind of go through what's required, the device was the easy part. It's all the operational pieces. And so I guess I fall back on my previous comment to make sure that you've got a good structure in place on that intake side for that specific use case. I don't know, Dr. Alper, maybe when you were looking at use cases or specific clinical conditions that you guys are going to say, okay, that's good to go for at-home care, was that part of what could be monitored and then how they were going to follow up, or it really didn't matter as much because you're going to have the hospitalist sort of on call for those things?
Absolutely. I think that we're trying to anticipate those contingencies as they're, because we know that they're going to happen. How we would take care. I'm a hospitalist, so how I would handle those patients in the middle of the night, like they'll handle the patients in the middle of the night when they're at home. I think that we're actually walking through that process of outlining what all those alarms ought to be set at for our monitoring team this week. We're going through. We have the starter set of what's recommended, and then our expert team is working with the current health team to adjust those and to set up our initial settings. We're figuring out again, when do you call 911? When do you call our mobile integrated health paramedic that's going to go into the home and can give that shot of Lasix, or who can take some additional interventions, versus when is it that it's going to go to our overnight hospitalist who's going to be able to tell the patient to reassure them or to provide a little bit of additional guidance on something they can do and answer their question remotely. I think that these are all the protocols that we're trying to lay out right now, and I think again, our team is very engaged in the process, and again, getting those settings right so that we're not over alerting, we're not over activating, but at the same time we take care of patients as safely as possible is kind of the that's kind of the secret sauce, and it's going to take some PDSAing, but erring on the side of caution.
Maybe moving from alarms, I'm curious, Dr. Alper, and you've touched on this a little bit, but what are you looking at mainly from a metrics perspective, but perhaps across the clinical and economic domains? What to you will prove that the investment that you're making in hospital home is worth it? What are the key metrics for you?
Yeah, you're right. We mentioned a few of them. Of course, to be compliant with the CMS waiver, we have to track a few things like the any unanticipated mortality. What's our volume in the program? Any unexpected transfers back to the hospital for admission? Of course, these things are always possible in the hospital as well, that patients may have complications. So, but then we do want to track things like overall length of stay. We want to track the cost and whether the cost is going down. We want to track the number of times that patients get readmitted into the program. How many times are patients going to skilled nursing facilities relative to what we're seeing to our patients who are being admitted to our hospitals. And other quality metrics as well. And another thing, like I mentioned, we're seeing a lot of patients that we have to turn away from not being accepted from transfers. So are we seeing any fewer patients that are turned away related to transfers as we take more and more patients into the hospital home program? I think quality, financial, operational metrics will be. We have a weekly meeting on generating those reports at this point as well.
And I guess I think hospital at home is obviously everyone is thinking about it right now, and you are very close to getting your first patient into that program. Sitting here now, Dr. Alper, is there anything you would do differently? If you were another health system in America who's just at the start of that journey, would you do anything differently than you have done?
No, I think so far I'd say that I've been really pleased with the path that we've taken. It's we had a really great team that we put together to help to build this. A nursing leader, physician leaders, and operational leaders, our IT team, and it's just been an incredible effort. Things seemed to go really, really smoothly for the initial couple months where we started to line things up. And then we got into the harder problems, so some of the order transmittal, some of what we talked about before. How do you make the order go to the partner instead of going to the, what's the inpatient pharmacy where it always went before? So it's a lot of the stuff that's behind the scenes. Medications are going to be complicated, and that's partly due to some of the federal regulations and due to, the practices that we can take. So how do we make sure that the medication that gets ordered, depending on what kind of medication, whether it's an infusion or a injection or a pill, make sure, or it's a controlled substance, that it goes to the right pharmacy. Those have been some of the more challenging questions. And, but we've got a great team that's knocking out every one of these barriers. And I can't think of anything that we would do differently if we had known that now. I think, it's just been a great experience so far, and really excited to get started.
So I thought we might finish, and we'll hopefully have time for maybe one question, but I'd love to know from both of you, maybe starting with you, Dr. Oliver, what over the next 2, 3, 4, 5 years, where do you see healthcare at home, remote care, where do you think things are going to go? Maybe starting with you, Dr. Oliver, from Baptist's perspective.
Sure. Well, I'm certainly not going against Dr. Alper and saying hospital at home's got no future. I think it does, or I wouldn't be here. And I think we'll start moving towards that as well. I think the integration into existing systems is key. Just, to touch on the ambulatory RPM billing piece, when you've got a third party monitoring your patient initially, and then you've got our home care team, and then the patient's chart within our Epic EHR. Initially, that was 3 different places that information existed that you're trying to get together, let's say for billing or patient care. Really challenging to do all that. So we now have our home care team on Epic, their home care module, and we're launching our integration with the RPM with Current Health then later this year. Once that's there, I think it's really helpful, because with RPM, I think one of the challenges, and really anything coming from the home, whether it's a smart home, I saw a question in the chat, data coming there. How do we get the data to the decision makers in a way that's meaningful? We've integrated Fitbit data into Epic years ago. I hate to pop any bubbles on the team that did that on my side, but it's really neat, but clinically useless. Like I've done it on myself, and you just get a series of heart rates and like, okay, wonderful. And now am I just liable for that? So we've got to be able to present the clinically relevant information to the decision makers, whether that be a nurse or a physician or a PA or what have you, and then where they can make a decision on it. They're not having to cure through the data and figure that out. And I think that's one of the next steps for us is where do we put that data in a secure way, but then we can present it to the decision makers, the clinicians, in a way that's helpful to the patient. And that's coming. I think, you've got all the effort at interoperability and things in other areas throughout our nation, at least. But it is a challenge because you continue to push more data around. You have to worry about your security pieces and all that, as well as is it relevant data? Do I want that data? And so depending on the clinical scenario, I think that's it. And then, I think just continuing to educate. Everybody was our audience when COVID hit from a digital telemedicine perspective, because that was the only way they could see their patients. Now that that's been, at least where we are, relaxed and people are being seen in person, we need to remind them of the efficiencies and the digital capabilities of remote patient monitoring and other digital services, so they can be thinking of how best to utilize it for their patient. It doesn't need to come from IT. I mean, I'm a physician and I can help in that, but you've got to involve the clinicians. It has to be, somebody coming with the clinical problem to solve, and then we can throw the technology at it and help them in that regard. So I'll stop there. Thanks.
No, that was perfect. Thank you. And I guess, Dr. Alper, same question for you. Where do you see healthcare at home, hospital at home, remote care management going over the next few years?
Similar answer. I think we've been working in a world within healthcare where we see patients within our 4 walls, whether they be in the clinic or whether they be in the hospital. And with the advent of these digital technologies, people are wearing devices that are providing data all the time to themselves the ability to understand what's happening with patients, what's happening to their blood pressure between those 3-month blood pressure check visits. We can intervene on that more in real time. The concept of having a team of people who's looking at the population and being able to intervene. I've heard one of my mentors, Dr. Bob Wachter, refer to these. You need a team of care traffic controllers that are looking at all this data that's coming in. It's not the kind of thing that a doctor is going to be able to take all that data and be able to process it on their own. But I think that if we want to take better care of the population of patients, keep patients healthy, then that's what it's going to take is leveraging all of this data that's coming in from the community and being able to help patients to take better care of themselves in between visits.
Fabulous, thank you. So we have a couple of minutes left. We have a bunch of different questions in the Q&A, and we're unfortunately not going to get time for maybe more than one of them. One of them here, and maybe it's a question to both of you, is to what extent have you involved clinicians in designing your respective programs? Maybe Dr. Oliver, first to you.
Oh, it's been critical. I mean, we can bring the technology forward, and it's always a temptation as a clinician myself to jump in there, but make it a concerted effort to say, we can't, IT and the monitoring, but we can't drive that. It's got to be driven by the clinical staff and clinicians themselves. And so, yeah, that's part of our intake process for new use cases is who's bringing it to us, and do you have that engagement? You've got to have that clinical champion, at least one, if not multiple ones, for it to be successful. Healthcare moves slowly. We've moved so fast in the last 18 months, make your head spin, particularly historically. We're that big super tanker that does not turn on the dime normally. And so as an organization, we're looking at how do you turn more quickly, because we realize, hey, we can do it when we're focused. But I think with that, you have to recognize there's been a lot of change in the last 12 to 15 months for the clinician, the person taking care of the patient, nurses, et cetera. And we have to be sensitive to that. So their involvement is critical, and we try to include them every step of the way.
And then Dr. Alper, your perspective on that?
I agree completely. We've engaged clinicians from the start, and they have driven the program. Again, I'm the chief quality officer for the system, and that's just the most important thing to me, is that patients receive high quality, safe care, and that's something that really needs those clinicians to be able to understand and to help to drive the decisions that get made that will involve patient care. So having an outstanding multidisciplinary team that involves all the different disciplines, the administrators, the IT people, but also the pharmacists, the nurses, the therapists, the dietitians, the physicians, I think is really what ultimately is required in order to make a comprehensive and really high quality program.
Dr. Oliver, Dr. Alper, I just want to say thank you so much for taking the time and sharing your experiences. I know you're both incredibly busy, so thank you for doing so. I'm sure everyone found it incredibly valuable, and I hope you all have a wonderful rest of your day. I'll hand back over to Vanessa.
Thank you all for that discussion. It's amazing. And thank you for attending this session. We hope you found it insightful and educational. Please note we have a few more sessions to go within the Remote Patient Monitoring Virtual Summit. If you are interested in attending any of these upcoming sessions, click register for upcoming sessions under the resource list. That concludes this Remote Patient Monitoring Virtual Summit session. Again, special thanks to our speakers, Brett, Eric, and Chris, our audience, and our sponsor, Current Health. From the team at the Remote Patient Monitoring Virtual Summit and Extelligent Healthcare Media, thank you all and goodbye.